Hi everyone, I'm Zarir.
You're not married?
So today we're going to be presenting about implant placement prognosis. This presentation was done by Cecilia, Russ, Aaron, and I. So to start off, we're just going to do a quick introduction. So as we know, even in clinic today, we've been having more and more implant placement in edentulous spaces that we have. And we wanted to see for when exactly should we be placing an implant? Should it be right after you extract an implant, or should we be waiting a little bit before we place an implant so that we can get the best outcome for our patients? So we know in previous literature that it was believed that you wanted to give the socket enough time to heal. So normally a periodontist would do an extraction, they would do a bone grafting if it was needed in the socket, let that heal completely until a new bone had started forming, so that when the implant was going to be next placed, there would be enough bone there for osseointegration to actually occur. So as we know now, we have newer methods. So a lot of dentists are starting to placing implants immediately and not waiting for any real healing to occur. So they'll extract the implant, they'll extract the original tooth, they'll place an implant that day, they'll suture everything up, and everything will heal together. So this is called an immediate placement of an implant. And it seems that this is one alternative that can be used today. And it's really sought after by dentists because you only need to do one surgical site. So you would do everything at one surgery versus previously you do the surgery for the extraction, the bone graft, you'd suture everything up, and then you'd have to do a second surgery to place the implant. So we wanted to really determine if there was a difference in the outcome for when we were placing implants. So we're comparing immediate implants, which would be same day, versus an earlier delayed placement. And our systemic review looked at that, and this PowerPoint is going to look at that as well to figure out what the best prognosis will be. So for our PICO, we came up with the question, in patients receiving dental implants after tooth extraction, would using early implant placement protocol compared to delayed implant protocol lead to significant changes in long-term implant prognosis? So our population is obviously patients who have edentulous spaces and are receiving implants. Intervention is going to be early implant placement, and the comparison is delayed implant placement. And what we're really trying to figure out is which one has the best long-term prognosis. So we're just going to go over some definitions because this is key to not only our review, but the presentation today. So a lot of authors define these terms early, delayed, and late different ways. So we have a list here of a bunch of the authors that we looked at. As we can see, there's a lot of variations. So some of them only really look at one thing. So if we see like number 2 here, Block et al., they really only just looked at delayed implants. So this is important because there's a lot of limitations to these research articles because they might only be looking at one thing. And we have to keep in mind that their definitions are also not the same. So these are just some more reviews that we looked at. So using these, all of these articles, we were able to compile together what we want to call our definitions of immediate, early, and delayed and late, which are kind of the same thing. So this was using a lot of the authors. Most of them do agree on statements, even if they're only looking at one thing. Like I told you, like Block was only really looking at delayed. But we're able to put all these together, and the definitions we came up with was immediate, as we already talked about. So you're doing the extraction, and the same day you're going to be placing the implant. And then if there's a need for some sort of graft, that would be done at the same exact visit. Early implant is really talking about soft tissue healing. So what the goal for that is, once a tooth has been extracted, if you need a bone graft, again, you would do that. But you want to give that bone a little time to heal, as well as the tissues around the socket to heal. So most of the articles were in consensus that this was about 4 to 8 weeks. However, some of them did go all the way up to 12 weeks of time for their reviews, for allowing there to be enough time for healing for the tissues before going back in for second surgery for the implant placement. And then finally, delayed, most of them agreed that this was after longer periods of time. So most of them were saying over 4 months, and a decent amount of them did use the term late as well. So a late placement, they were really using 1 year as the landmark. So again, you do the extraction, then you would be able to have the healing of the site, and then about 1 year later, you would come in and place the implant. So a little background on why we decided to really go into this topic. So we know that there's previous research out there that shows that there's some bone resorption that occurs just generally over time when there's placing an implant. So one review that we saw was Secanthian, and they showed that you get normal vertical and horizontal bone loss of the bone and the tissue, respectively, after an implant has been placed, after the tooth has been extracted. And then previous research has also shown that this bone loss really occurs the most within the first 6 months after the extraction. So as the body's healing, a lot of changes are going on, and your body has normal reactions to kind of try to adapt to the new situation. So once the extractions occurred, we do see a little bit of bone loss. And the goal is to try to preserve as much of this bone as we can for the implant placement. And this will help us preserve the ridge height. And then as well, it helps us preserve the tissues that are on top of that. So when we're looking at results, the first thing that we looked at was implant survival rates or the failure rates. So all of the studies really did go deeply into looking at the rates of survival or the rates of failure. So one article that we looked at was Mish et al. And they really were key because they were able to define what determined if an implant was successful or if it was a failure. So they defined successful implant if there was no pain, no tenderness, no mobility, no exudate, and no radiographic bone loss less than 2 millimeters from the initial surgery of the implant. So this is pretty key because we want our implant to be most successful for the patient. So knowing what we use as a definition is key to figuring out if our implants are a success or not. The other key thing, a lot of people are probably wondering where this 2 millimeters is coming from. So this is what I was just talking about. So once a tooth is extracted, we have bone remodeling that normally occurs in the body. So they wanted to set a parameter of 2 millimeters, which other previous people have researched, because this is expected loss. So they didn't want to call any kind of implant a failure just because there was a little bit of bone loss. So the 2 millimeters is kind of what's expected. Now, they said a satisfactory survival is when you start getting more bone loss, right? So if 2 millimeters, up to 2 millimeters is expected, if you start getting bone loss of 2 to 4 millimeters all the way around the implant, they call it a satisfactory survival. We start coming into compromised survival when we have anything that's starting to create even more bone loss. So when we start getting more than 4 millimeters of bone loss, and if we start, which means that our probings would start reaching about 7 millimeters, this would be compromised. And then clinical failure is anything that's causing pain, discomfort, and if there's any sort of mobility or severe bone loss, such as bone loss on half the length of the implant, we consider that a failure. So another article that we looked at, so they were looking at implants placed all over the mouth. So they looked at anterior and posterior maxilla and mandible, and they didn't see any significant failure rates between the implants. So this study specifically looked for immediately placed implants, and they compared this to implants that were placed 3 to 5 weeks after healing. So we're looking at an immediate placement versus early placement. And these researchers saw that really wasn't much of a failure rate between the two. They did, however, see that failure rate was much higher if there was a previous periodontal active disease. So this is pretty key because, as we know, periodontal disease obviously leads to bone loss and issues like that. So if a patient's already seen some sort of bone loss, the implant failures, no matter what method you see, starts to be more likely to fail. And this research was supported by Grundle in 1999, who also had the same results. So he came to the conclusion that when you have periodontitis, an active disease, your failure rate will increase significantly. So other researchers looked at other stuff as well. So Annabelle saw that there wasn't really much of a difference in survival rate between early and late. So they looked at early for 2 to 6 weeks, as well as late. So this would be fully healed. So this is what we're looking at, the 4 or greater months, even up to a year. And they saw 100% survival rate for all implants. So this doesn't show much of a difference at all. And then we have 2 other researchers as well who had the same results. So we can see for implant placement, as long as the site's healthy, there isn't any periodontal disease. We can see that whether you're placing it early or delayed or late, all of them seem to have similar success rates. So this tells us that we can reliably place implants after extraction as long as our site is healthy. So we don't want there to be any periodontal disease or any previous periodontal disease, and we can expect great results. So this is just a table from Soyden. So what we can see here, group 1, which they looked at, was immediate placement. So this is, again, you're extracting the tooth the same day and then you're placing the implant right then and there, versus group 2, which was the early placement. So this is waiting 3 to 4 weeks, letting the tissues heal. And we can see that survival rate for the first group overall was 96%, and the second group was 100%. And with these numbers, they didn't find a significant difference. So it might seem that, it's slightly less for an immediate placement, but once you figure out the statistics behind it, there isn't really any significant difference between the 2 groups. And that's probably because the sample size was pretty low in this, as you can see. So another thing that these articles looked at, other than success rates of the implants, they really wanted to dive deeper and look at the bone resorption rates. So we wanted to look into this and see what are the success rates. So are we seeing more bone loss in one type of placement versus another? And it seems, again, that the authors really did conclude together that there wasn't any significant difference at what time you were placing the implant. There wasn't any change in the bone loss that we saw. So Shroop saw that there was no difference in the alveolar crest height, and they evaluated all three. So they looked at early, delayed, and late, and they did this over a span of 10 years. So we know that their evaluation is pretty good because it's over a long period of time. And they looked at all three, and they saw that there wasn't any significant difference. Annabelle and Block also did similar things. So Annabelle looked at bone levels and the tissue levels, and they compared immediate and early, as well as late. And they saw that there was no difference. And then Block, as we talked about, they looked at immediate placement and delayed placement, and they saw the same thing. So there wasn't any differences in any bone or tissue level. So other researchers, however, that have just taken out articles more recently have seen that timing does matter. So we're able to see in an article published in 2021, they did see bone levels differed based on the timing an implant was placed. So they were specifically looking at the buccal plate thickness, and they saw that if they took radiograph images, they were able to see that the implants placed immediately after an extraction had more buccal plate loss than compared to delayed or late placement after 4 months of healing. And then in 2017, another article came out, and they looked at bone loss continuously. So they measured at 1, 3, 6, 12, and 24 months. And they saw that implants that were placed earliest had bone loss compared to immediate placement and delayed placement. So again, there was consensus before that there was no bone resorption, no matter what time you place it in, but newer research is starting to see that there is actually a difference in resorption levels around implants based on when you'll be placing them.
All right, thank you, Zarir, for that presentation. Continuing on with the results, we looked at a paper at Tenetti in 2017 that compared early and delayed implant placement. And what they saw was that 72% of the implant sites required bone augmentation in the immediate placement implants versus the delayed implant placement sites, where only 43.9% of sites required that bone augmentation. And that delayed group was, again, about 12 weeks post-extraction. Continuing on, they also noticed a failure rate in that immediate placement group of 5 times what the delayed group was. That's 26.1% versus just 5.2%. And they also looked at the aesthetic score. Now that's the pink aesthetic score, which is 7 different groups, including the mesial papilla, the distal papilla. And those are all grouped 0 to 2, with 0 being poor and 2 being excellent. And they also found that the immediate implant group was lower than the delayed implant group. Moving on to a different study, Block did not notice a significant difference between that immediate placement group and that delayed placement. However, they did conclude from that study that the restorative dentist was key in maintaining those gingival levels of facial tissue, which is what those pink aesthetic scores in the previous study would have studied. We got a picture here from the Tenetti study, and this is just showing a few graphs, including the implant position, distal, midbuccal, mesial, and the immediate and delayed implants. You have the width of the bone defects when they did find a bone defect in the immediate and delayed implants, and you can see the size of them, and you can see where those defects occurred in the distal placements and the midbuccal placements, and you can also see the depths of those defects, and that's on the lower right. Moving on to the discussion. So these articles all agree that there's not many significant differences in implant survival rates when using immediate, early, or delayed techniques. There is some evidence that the early or even the immediate implant placement group maintains those peri-implant, the marginal bone levels, as opposed to the delayed or late implant placements. We saw some of that in the Prati study. Now, this can be attributed to bone modeling, and significant bone modeling occurs about 6 months after extraction. It's also concluded that the immediate or the early implant placement protocols are appropriate and favorable when the bone levels must be maintained. So when you want to maintain some of that peri-implant marginal bone levels, then those immediate and early implant placements can be a favorable option. Now, most of the authors of these papers agreed that the bone absorption is going to occur no matter when you time the implant placement. That's to be expected. We talked about that previously. Zarir mentioned about 2 millimeters of bone resorption is expected. But the newer research shows that the buccal plate thickness is maintained the most in immediate implant placement, while the marginal bone loss is the least also in that early implant placement groups, about 2 to 3 months after extraction. Continuing on, there is some disagreement between these papers on the bone loss surrounding the implant on that paramarginal implant bone. The Prati study concluded that early implant placement is the best technique to maintain that bone 2 to 3 months after extraction. And the Sinarthistan study found that delayed implant placement technique placed 4 more months after extraction resulted in more immediate bone loss than the immediate implant placement technique. Conversely to these two studies that suggested to maintain some bone early or immediate placement, the Schrapp and Alabali study found there's no difference in peri-implant bone levels between implants placed in these immediate, early, and delayed groups. So the clinical implications of some of these studies are that early implant placement is a viable alternative to immediate implant placement. And if there's no unfavorable conditions in the site, such as infection can obviously negatively impact that implant survival rate if placed immediately and not allowing that infection time to run its course and heal and become a more favorable implant site. Results also showed that the implant placement, placing that implant early, 1 to 2 months after extraction, may lead to greater peri-implant bone levels than delayed implant placement waiting 6+ months. But between these two groups, there didn't show significance in success or failure rates of the implants. So the conclusion of our systematic review and what most of these articles and author conclusions came to was that there's no significant differences in short-term survival or success between the implants placed in early versus delayed techniques. The implant placement greater than 6 months, those delayed implants after extraction, may result in decreased peri-implant bone support compared to the placement in the early category, which is 1 to 2 months after extraction, which may have a greater showing of peri-implant bone levels. And these are our sources numbered. Any questions? Let us know. Thank you for your attention.